procedures. Just a disclaimer. We'll just get past that. Okay. By introduction, pain is sometimes known as the sixth vital sense. Pain is actually very difficult to objectify. We use things like ranging emotions, which may be a better metric compared to a visual analog scale when measuring pain, because it's a very subjective type of experience. This is the visual analog pain scale that is often used. We try to put an objective number as a way to compare one person's pain to another, or a person's pain at one time to another time, and to monitor treatment. So this is the way that we can try to objectify the pain experience. So when you consider these, when you consider that these are the tools that we use in orthopedics, you can imagine that pain can be an issue. Luckily, in the operating room, the patient is asleep, but there are a number of orthopedic procedures that are done in the outpatient clinic. And some of these can be quite painful. There have been a few studies that have actually measured pain in an outpatient fracture clinic, but the literature is very scarce on this. Some of the studies have measured, what's the pain experience in removing an external fixator in an outpatient facility, even suture and staple removal, and then K-wire removal also has been studied. But there's been very little study in the measurement of the pain experience in outpatient settings. So pain control in outpatient procedures is actually an unmet need. In order to assess this objectively, we need to do a study. If we want to improve on pain control from the current techniques, we need a control group. I'm going to first talk about how we developed a control group to understand where we are, and then comparing to this control group, we can evaluate the effectiveness of neurotreatment alternatives that we may want to introduce in the future. And part two of today's session will be Dr. Rivlin, who's going to discuss the potential for filling this gap using Penthrox. In order to create this control group, we did a study. This is published in the Journal of Orthopedic Trauma and Rehabilitation. And this is really the control group that we're using, and basically an understanding of this unmet need in orthopedics or in any outpatient setting. We want to measure patient-reported pain as well as the healthcare professional's perception about what procedures in a fracture clinic setting are painful and how painful are they. This, in effect, is identified as the unmet need. The objectives of the study had primary and secondary endpoints. The primary endpoint was really to measure the worst pain experience during the procedure, as measured through the highest pain score on the visual analog scale, which is an 11-point scale. Secondary endpoints were pain measured at baseline, at 5-minute intervals, and at 24 hours post-procedure. We also looked at how much pain medication was used at baseline at the 24-hour mark, and we looked at the different procedure types, the drug types that were used, the doses, and the frequencies. The procedures that we investigated were the ones that were the most commonly seen in the fracture clinic: removal of external fixator pins, removal of K-wires, staples, sutures, halo fixator pins, cast manipulation or removal of casts, removal of prominent bone screws, and patients that were undergoing casting, splinting, or retorquing of halo pins were also included. Some patients had more than one procedure that was being done at any one visit. Enrollment was from March to December 2021. We had 51 individual patients at the Sunnybrook, or 51 procedures that were used in this cohort. Pain was evaluated at 3 time points: during the procedure, 20 minutes post-procedure, and 24 hours post-procedure. Again, the visual analog scale is used. It's an 11-point scale: no pain, moderate pain, or worse pain. Here is a breakdown of the patient demographics. It just gives a breakdown of the age, the male-female distribution, the number of diagnoses. Some had 3 diagnoses, some 2, some 1. whether the treatment was follow-up of an operative procedure or whether they just had non-operative treatment, such as cast manipulation or fracture manipulation with placement of a cast or removal of the cast. The anatomical locations are just listed, and whether there was previous opioid use or not for pain control, and the vast majority were on pain medication. Here is a breakdown of the procedural types: cast splint removal, cast splinting, and again, one of the more common ones, suture removal or external fixator removal, and then a smattering of halo removal, K-wire, screw removal, and staple removals. This is a breakdown of the pain medication that's used, and you can see that each of the types of procedures are listed with what pain medication are being used for each type, and the vast majority are on hydromorphone or an narcotic medication as a pain control during the procedure. So this slide is a little bit busy. It's the overall breakdown of the data. I'm going to divide this out in a number of slides after this. But what you can see here is that along the top are the procedure types. Along the side are the baseline pain scores, the worst pain score during the procedure, and then at post-procedure, and then 24 hours post-procedure. And what this is showing you, the highlighted areas here, these are the ones that are the significant, or the ones with the highest scores during the procedure, the highest scores at the post-procedure, and the highest scores that are 24 hours later. So let's just break this down a little bit individually. And this, again, is an overall graph showing you the pain distribution during the baseline, during the procedure, post-procedure, and follow-up. I know it's a very busy slide, but you can see that they're broken down by the X-fix removal, and at post-procedure, you see it's the highest point here, and the K-wire removal is the next highest point, and then we have the screw removal, etc. So if we just break this one down again further, you can see that this study demonstrated that patients undergoing the outpatient procedures in the fracture clinic do experience pain and are taking a variety of pain medications. The procedures with the highest mean difference in pain scores during the procedure were the X-fix removal, the K-wire removal, screw removal, and then halo removal. And again, so that's during the procedure, and those are the four highest painful procedures. If we go to the post-procedure, the procedures with the highest mean difference, that is the baseline to the peak pain, and we're looking at the difference between those two, at this post-procedure were screw removal, cast splint removal, K-wire removal, and X-fix removal. And then at 24 hours post-procedure, the procedure with the highest mean difference in scores at 24 hours were, again, just these ones that are listed: K-wire removal, screw removal, casting, splinting, and X-fix removal. So overall, what does all this mean? Before I go there, I'll just want to say that one of our secondary objectives was to look to get the perception of the healthcare provider and what was their perception of pain associated with each outpatient procedure. So we actually asked the medical staff, the nurses, the doctors, and even the cast technicians, how did they rank, or how would they rank each of these procedures if they had to give an idea or had to feel the pain themselves. So we had them rank it from worst pain to the least pain to the worst pain. And here is the ranking, how they did that. And rank 1 to 2 is the least amount of pain, and rank 7 to 8 is the highest amount of pain. And you can see the ones that they thought were the highest amount of pain were the halo removal, external fixator removal, and screw removal. And they felt least amounts of pain were more the casting, splinting, and suture removal. And again, this is just a summary slide. It's the ones that they rated the highest amount of pain were the screw removal, halo removal, and external fixator removal. And why does that really matter? Really, that they perceived, or they felt that they understood the pain as well as the patient, and there was some similarities, but there's also differences. The healthcare provider felt that this was the order of what was most painful, and the patients actually felt it was this order: X fix removal, KY removal, screw removal. I don't think that's so important, but everyone appreciates the fact that the patient themselves experiences the pain, and the healthcare provider also appreciates that these are painful procedures. So the unmet need for pain reduction is what we're looking at, and this is what I think we've shown in the study. The study demonstrates that there are outpatient procedures in the fracture clinic that cause patients high levels of pain. Patients were recorded taking a variety of pain medication for these procedures and are still reporting high levels of pain during, post, and 24 hours after the procedures. So there is a role for better pain management in an outpatient fracture clinic. Role for an alternative pain relief such as Penthrox, and why is that? Why would that be a useful medication? Well, self-administered to patients' liking based on the magnitude of pain experience. Methoxyflurane is non-addictive and simple to use, making it an effective option when fast-acting relief is required. It's non-drowsy, meaning that after use in a clinic, the patient would be able to drive home themselves, and it may reduce the prescribed use of narcotics to relieve pain or reduce the need for prescribed narcotics. So with that, I pass the baton to Dr. Rivlin.
Number 1嗰張就啱嘅啦，就要加啲嘢同埋改個地址。
Dr. Rivlin.
Thank you very much, Dr. Finkelstein. That was excellent. I especially like the comparison between pain scores by the patients as compared to pain scores by the healthcare providers, because that allows us to, as healthcare providers, better understand the patient's needs so we can adjust what we do in the moment as we deliver the painful procedure. Well, thank you for having me here at Sunnybrook at the Odette Cancer Center. It's truly a pleasure to be able to present grand rounds to you. You're probably wondering, why is there an emerge doc here talking about painful procedures to a group of oncologists? And I mean, you're probably used to just getting that 3 o'clock in the morning call saying, I have a patient here with febrile neutropenia. Can you please tell me what I should do next? And would you like to admit him? So this is not that, but you could put a face to the name now. A little bit about me. I've been practicing emergency medicine for about 25 years. I work as chief and medical director at Humber River Hospital, and we serve an area of approximately 800,000 people in our community. So we're a busy hospital, community hospital with some academic work there. We see between 350 and 400 patient visits per day. We have 20 physician shifts on during the day. So we have an opportunity to be on call a lot for the management of procedure-related pain. A bit of a disclaimer, there's an honorarium provided for this. Of course, as a speaker, I have full control over the presentation and the PowerPoint slides, and there is an honorarium that was provided. I thought it's always a good idea to start with a patient presentation. Kind of puts everything into perspective, and I'll let you step into my world. So this was the other day. I was working in the emergency department, and I saw a 74-year-old woman who came in with severe acute onset of pain. In fact, she was walking out of a rehab facility where she was there for 8 weeks, and she turned, she had a walker, and lo and behold, she fell, she broke her ankle. Long story short, she broke her ankle, the same ankle that the knee replacement was on, like the same leg that the knee replacement was on. So it was a mechanical fall. She was unable to weight bear. EMS took her to Humber. So it was an isolated left ankle injury. Her pain, by the time I had seen her, was 8 out of 10. And that was post-Dilaudid, 1 milligram. She has a history of osteoporosis, coronary artery disease, type 2 diabetes. As I had a chat with her, she said that she was told she cannot have general anesthesia nor conscious sedation. Why? She did not know. I went on Connecting Ontario. I was unable to determine why. Anyway, on exam, just focus exam on the leg, of course. Normal pulses, left ankle was deviated laterally. The skin was intact, normal neurological features, lots of pain. And this is what it looked like. So what you'll see here on the image on your left is that the talus is completely displaced to the left. The mortise is completely off, and the distal fibula is fractured. And then on the lateral, you can see that the talus is displaced posteriorly. And if you look closely, you may not see it, but there's actually a posterior malleolar fracture there as well. So the treatment plan. So she already had 1 milligram of Dilaudid given by medical directive. The patient complained it didn't work, but when I walked into the room, she was asleep. I had to rouse her. So obviously she had some relief, but like I said, that was a pain of 8 out of 10. It's a busy emergency department. The respiratory therapist wasn't available. They were in a resuscitation in the acute area. So it was myself and the nurse. And I said, why don't we use Penthrox? We've used it in the past for these kinds of procedures. Let's go with this. It'll be faster. We'll get it all done. And while I was preparing for the splint, the nurse initiated the Penthrox with inhalations. And then we started the closed reduction no earlier than 4 minutes after the onset of the use of Penthrox. After about 10 minutes, the reduction was completed. The patient did moan and groan a little bit during the reduction. I will not lie to you about that. That's for sure. But when I asked her what was her maximum pain score during the reduction, the ankle reduction, she said it was a 4 out of 10. And then post-procedure, she was wide awake. And during the procedure, she was awake and speaking with me and puffing away on the pipette. And then post-reduction, we achieved a really great closed reduction. You can see everything is aligned. She still requires surgery for this, but there was a lot more comfort following the procedure. So let's just talk about the trauma continuum a little bit. In a pre-hospital setting, we tend to not use systemic opioids. Then once you get into the hospital, there's certainly a significant amount of opiate medication used and available. And then in discharge follow-up, you want to minimize the amount of opiates and any addictive substances you send patients home with. So you ask yourself, what is the ideal? Let me just remove this here. Oh, there we go. What is the ideal analgesic in a trauma-related case? Well, I'll tell you right off the bat, it's Penthrox. Why? Because, and I'm not trying to pitch it to you or sell it to you, but it really is. It's an effective analgesic. It's fast. It's fast onset, fast offset. It lasts long enough to get the procedure done. Once they stop puffing on it, it's cleared within 15 to 30 minutes. It's easy to titrate. It's self-administered. And we know that self-administered analgesics are more effective than those that are administered for us when we ask for them. It has a safety profile that's really great. It's non-dissociative, not addictive. It's portable. And there's a very little adverse condition impact on it, which is great for crazy people like emerge docs who like to work in high altitude, low altitude, freezing climates, and basically in wilderness medicine. And it's affordable. So let's just, looking at the broad variety of medications that we have at our disposal, and for any patient, you can use anything from Tylenol on one hand to, let me see if I can move this window up a little bit. There we go. To midazolam, although that's not a painkiller, it's for sedation. But you can use this whole wide spectrum. So where do we use Penthrox? It kind of hits the mild to moderate, and moderate to severe area. Once you get into severe pain, you really severe pain, trauma pain, femoral fractures, stuff like that. You want to get into, ketamine, propofol, IV opioids, fentanyl. Yeah, I'm trying to move forward on this. There we go. Well, what is methoxyfluorine? Methoxyfluorine is a fluorinated anesthetic. Its proposed mechanism of action is it disrupts neuronal transmission. It potentiates GABA receptors. It alters membrane fluidity. It decreases gap junction. You probably all know all of this stuff. The gap junction part is where cells interact with one another simply because they're in close proximity and their cell walls touch. The exact mechanism, at the end of all this, the exact mechanism isn't exactly understood. It's clear, it's colorless, it's a volatile liquid. It's a little bit oily to the touch, and it has a characteristic fruity smell. In high doses, excuse me, it's an anesthetic agent, and in lower doses, it's an analgesic. And as an analgesic, As an anesthetic, it's linked to hepatotoxicity and nephrotoxicity, and you'll hear about that. So I wanted to spend some time talking to you about what happens with that. But as an analgesic, it has very few side effects. So of course, you're naturally asking, as I asked, well, what's the difference between the anesthetic and analgesic effect of methoxyflurane? Just, to let you know, it's kind of making its way across Canada. When we started using it in 2018, 2019, it was considered to be new, but in fact, it's been used for many, many, like decades, and it's fairly new to Canada. But these are some of the centers that it's used at. So to understand methoxyflurane, I'm just going to explain the MAC value to you a little bit. So the minimal alveolar concentration to produce anesthesia is the minimum amount of the drug that you need in order to have a patient, 50% of patients move during surgical incision. Kind of sounds cruel, but that's how it's figured out. So long story short, methoxyflurane has a 0.16% MAC value. What does that mean? That means that when you compare it to halothane, isoflurane, like its basic colleagues and peers and competitors, it's more effective at a lower dose, and you need more halothane, for example, to have the same effect. And then, of course, when we talk about analgesic versus anesthetic, if you're using this and the patient is awake and your MAC hours is less than 2 MAC hours, which is that much, that MAC value over 1 hour, then you're not going to get, it's very unlikely that you're going to get a toxic effect. How does it work? You breathe it in. And it's important to breathe it out through the pipette as well. I find that some patients do use it as a vape, so it's not a vape. But you breathe it in and out. It's metabolized in the liver. Usually cytochrome P450 metabolizes it, and it's eliminated in the kidneys. 20% of it is exhaled. And so sometimes as a healthcare provider, that's what you smell in the air. So I'm just going to introduce the pipette and the whole system to you a little bit. Its indication in Canada by Health Canada is for relief for short-term pain, for medical procedures or trauma in a conscious adult patient. It's supplied as an inhaler, and it's a 3 milliliter vial of methoxyflurane liquid. It's inhaled, and then the whole process is disposable. The whole pipette is about 15 centimeters long, and it's the vapor of the methoxyflurane that's inhaled. It's administered by self-administration. We set it up for the patient, we hand it to the patient, we instruct them how to do it, and we coach them through it. And one should expect onset of relief at around 5 minutes or so. So what a lot of people do, and we are as healthcare providers are used to doing it this way, is we give the medication, we start the procedure. You kind of have to train yourself not to do that. So you give the medication, you go do part of your setup, like I did, where I did part of my casting setup while the patient is getting the methoxyflurane on board. And I prefer to have a nurse present, not because I'm worried about the patient deteriorating, but more to coach the patient and also to have an extra set of hands in case I need them for the procedure itself. So this is what it looks like on a cross section. And what you see here is the green pipette is cut in half. The white is a wick. So you kind of pour it into the wick so that when patients breathe in and out through that mouthpiece, they inhale air that kind of goes across the wick. And then when it's exhaled through the scavenger, which is a charcoal filter. Some of the contraindications is severe hemodynamic instability, pronounced respiratory impairment, malignant hyperthermia, or severe adverse reaction, renal impairment, liver disease, or if the patient doesn't know how to follow directions. What are the effects on vital signs? Very minimal. There is a small drop in the mean heart rate by about 6 beats per minute. There's a drop in respiratory rate, and there's a very small drop in blood pressure as well. But really, if you think about it, if the patient is in pain and there's a heightened adrenergic drive, you take that away with a pain medication, and you're going to see a drop in all of these measurements of their vital signs anyway. Just the important part was the drug interactions that for me is critical when you're looking at adverse event outcomes. So enzyme inducers that increase the rate of methoxyfluorine metabolism might increase its potential toxicity. So cytochrome P450, so alcohol, isoniazid, phenobarbital, rifampin, all of those increase cytochrome P450 activities, and so you get more metabolites. CNS depressants is not a contraindication, as with my patient who received Dilaudid and then also received the methoxyfluorine. I find the two work as adjuncts with one another, but you do have to monitor them a little bit more closely if they've already had a narcotic on board. And then use of concomitant nephrotoxic agents such as antibiotics, tetracycline, gentamicin, even NSAIDs, not an antibiotic, but even NSAIDs in fragile individuals could cause some renal impairment in the long term. Just some safety information, additional safety information. So it's very rare, but in cases between 1 in 1,000 and 1 in 10,000, there's a report of hepatic failure or hepatitis. Other findings with methoxyfluorine were nervous system disorders. So of course, some patients experience drowsiness, agitation, restlessness. A few do have a bit of dissociation. There's lability in affect, a bit of disorientation, altered state of consciousness. Some patients told me all kinds of stuff about them that I really didn't want to know about. And it's kind of like a truth serum. Others, most of them are just quiet. The nice thing is we don't get any combative behavior, which is really nice. With ketamine, you get combative behavior. Even with propofol, I've seen patients become combative and highly agitated as they kind of go in or come out of the sedation. There's a bit of choking and hypoxia during the respiratory system. Rarely, I've never actually seen hypoxia, and I've used this drug for 6 years now. Choking though, because sometimes the patients will take a breath in, it kind of hits the lungs a little bit, so they have to accommodate themselves to it. We talked about blood pressure fluctuations, and then of course we talked about hepatic and renal, and some folk talked about blurred vision and nystagmus. When we looked at Australia, who's been using this for about 40 years, and there are 3.5 million vials used at the time that I made this slide. The largest use in Penthrox worldwide, it's used in kids, pregnancy, and lactation. And really, there hasn't been any significant long-term effects or even short-term effects. Occupational exposures were 4, intentional product misuse 3, drug dependence 3, hepatic impairment happened in 8 people, malignant hyperthermia happened in 1, and renal impairment in 4 people. When you look at the psychomotor and cognitive effects, and the reason that this is important for us is because if you have a patient who, I mean, there's a lot of reasons why it's important, but one of the reasons it's important for us is when you have a patient who's going to drive themselves to your clinic, you're going to do the procedure, and then you're going to potentially expect to drive themselves home. You got to make sure that this is safe. So there's no contraindication right now for driving post the use of Penthrox in a clinic setting. And that's because when you look at the 15-minute sort of outcome post-Penthrox, patients' performance on some of these cognitive tests and psychomotor tests had started to return to baseline. And after 30 minutes, there's a full return to baseline. Occupational exposure, so you smell it in the air. And even myself as a care provider, when I'm smelling it in the air, I'm wondering, am I going to start feeling the effects of it? And can I continue to expose myself? But really, you're smelling it at 0.13 to 0.19 parts per million. And keep in mind, that's the 20% that they might be exhaling. And for it to cause any significant impact, it's got to be 15 parts per million. So it's really, it's got to be 100 times more than what you're smelling. So, but it is recommended to refill the inhaler in a well-ventilated area. Dosage and method of administration. So you kind of pour the 3 milliliters into a pipette and you have the patient breathe in and out. You have to set it up for the patient and you let them breathe it out of the pipette. You can use 6 milliliters in a day, 15 milliliters per week, and 1 course or 5 bottles per 3 months. And the manufacturer recommends that we not administer it on consecutive days. So this is the crazy part that I was telling you about when I talk about myself and my crazy emerge colleagues. And that is, yes, we've tried it out between minus 35 and 30 degrees Celsius. We try it in high altitudes and in low altitudes. And then we put it in a little bag that comes with it and we throw it out. But, you know, all joking aside, in using it in extreme conditions, this is a great drug because when you're up on a ski hill and you have an injured patient and they've got a broken tibia or a broken femur or a pelvic fracture and they're in extreme pain, you don't want to be fiddling with how you're going to administer Dilaudid or giving them anything orally. Well, this, you could just give it to them and they can self-administer the analgesic as we transport them down. And there are lots of case reports of this, including ones on Mount Everest, which I found to be very interesting to read around. More about the emergency department. So it's got a global emergency department use. It's multimodal and self-administered. You don't need to use it in a monitored room. So we can use it anywhere in the department. So when we're doing our fracture reductions, unfortunately, on busy days in the fast track area, we don't need to have them on a monitor. We discharge them very quickly, within 30 minutes, really. It usually takes more time to get that post-discharge instructions and care done than it does for the Penthrox to wear off. And and one of the reasons why we went with it at Humber was because it reduces healthcare providers. So you don't need an RT, you don't need an RN. I like to have one anyway, but if I don't have one, I'll just go with it alone. And you don't need a second physician in order to provide sedation. You don't need an anesthetist next to you. It's great during surgical procedures, as Dr. Finkelstein talked about, for hardware removal, joint manipulation, fracture reduction. In gynecological procedures, it's great for endometrial biopsies, IUD placement, colposcopies and LEEP, diagnostic hysteroscopies, minor operative hysteroscopies, even Bartholin's cysts, abscess drainage, ward catheter placement. So I'll end off by talking about this, the STOP study from 2014. This is a randomized, multi-center, double-blind, placebo-controlled study of the efficacy of Penthrox for the treatment of acute pain. And these are patients presenting to the emergency department with what we consider to be minor trauma. So we're not talking about multiple traumas that you get in the trauma room here at Sunnybrook. And it was conducted at 6 centers in the UK. Trial design, once again, randomized, double-blind, multi-centered, placebo-controlled, 6 sites, 300 patients. The patients were in age from 12 to 17, so there were 90 kids, effectively, and then 210 adults. The inclusion criteria was their NRS score of greater than 4, the pain score of greater than 4, between 4 and 7, due to minor trauma. Fractures, lacerations, burns, dislocations, contusions, or injury due to foreign bodies was the kind of trauma. The primary endpoint was to assess for a change in pain intensity as measured using the visual analog scale from baseline at 5, 10, 15, and 20 minutes and the start of from the start of drug inhalation. The secondary endpoint was, well, did they need a rescue medication? There were rescue medications available within 20 minutes of start of the treatment. And time to request the rescue medication, time for the first pain relief, the number of inhalations taken, and the global medication performance. And then the dosage regimen included either 3 milliliters of the Penthrox or 5 milliliters of placebo. The pipettes looked the same. The placebo pipette was literally dipped on the outside with Penthrox so that it smelled the same as the real thing. Dosage regimen, everyone got 3 milliliters if they want, or 5 milliliters. If they wanted more, then a second one was supplied, available on request. And this is just going through it again. So you got the 2 arms, 150 patients in each arm. You got the 2 separate inhalers, and then we measured pain from the start of the procedure every 5 minutes up until 30 minutes. And then there was a follow-up 14 days post-treatment. And this is just a busy slide, but what it does is, this is before any treatment. This is just a comparison of the pain scores, but also a comparison of the two groups, being the methoxyfluorine group on the left and then the placebo on the right. And it's just to show you that the two groups were matched in almost every way based on age, injury. I guess there were 3 burn patients, whereas in the placebo trial was in the non-placebo trial, there were none. And then I'm not going to go through all of the details there with you, but you can see that the matches were pretty bang on. So the primary endpoint at 15 minutes was that on the visual analog score, we saw a 34 millimeter reduction, or let me put it to you in another way. There was a 3.4 point reduction of pain in the methoxyfluorine group as compared to a 1.5 millimeter or 1.5 points, so 15 millimeter reduction in the placebo group. And you probably wonder, well, why did the placebo group have a 1.5 point reduction? And the authors postulate that it just could be getting into a healthcare environment, the ease and the psychological sort of alleviation of anxiety. But it's even with that, there's still a considerable difference. So when you look at it, you can see at the 5-minute mark, there's a huge difference between placebo versus methoxyfluorine. And then the maximal difference is at the 15-minute mark. So what that means for you is, as a provider of a painful procedure, if you want to plan your peak point of pain with the peak benefit of the methoxyfluorine from the starting point, you aim for 15 minutes. But there is pain relief from the 5-minute mark on. So just the conclusions from the STOP study was that there's a significant improvement in pain intensity compared to placebo. There's rapid onset of pain relief within 1 to 10 inhalations in about 85% of patients. The median time to the first pain relief was 4 minutes in Penthrox, 10 minutes in placebo, and there was significantly less use of the rescue medications with the Penthrox group. So analgesia with Penthrox was durable. It lasted over an hour, and the median time between dispensing the first and second inhaler was 54 minutes with Penthrox versus 50 minutes with the placebo. Just a couple of I don't have slides for this, but just a couple of points of where things are right now in terms of the management of or the study of Penthrox. Here we're looking at the pain levels of Penthrox, pain levels that Penthrox reduce when we're doing bone marrow aspirations. At Humber, there's a provincial quality metric for time to analgesia for patients coming into the emergency department in sickle cell crisis. And so we're actually running a trial. Obviously, we need to get Health Canada approval because it's not a procedure, but we're running a trial where patients coming in sickle cell crisis are going to be receiving Penthrox immediately while they're waiting for the rest of their pain management and sickle cell management to start. Thank you very much. It's been a pleasure.
So, thank you very much. So I'm just going to, any questions from the audience here? And I'm going to see whether there is any question in the chat room. Yep. So I'll ask Leon and Joe to come up here so that you can like answer the question, hear the question and answer the question right away. Okay. Okay, so question is the cost of the Penthrox.
Sure. So the cost of the Penthrox, each vial at the hospital costs about $55 when we buy it for hospital use.
So usually one
pipette. Yeah,
one pipette is good enough.
Yeah.
Good. So the question is, how is that compared with the like a standard of pain management in terms of the cost?
So for the kind of procedures that we do, if you think about a fracture reduction, that requires a respiratory therapist, a nurse to do the monitoring of obviously the physician, and then a second physician to provide the anesthetic, and then of course the use of a monitored bed. The cost of that for any procedure is around $1,000 plus, $1,000 plus. So, and then the medication itself, which would be propofol typically. So really we're reducing the cost to about $55 or more.
So in other words, it's actually potentially more cost effective and relieving the need for the healthcare professional in doing this. So let me see whether I can stop share and then come back to everybody here. Okay, good. Any other question? Yeah, I have to go back to see any questions from the chat. So my question to Joe Finkelstein is, you see, in the fracture clinic, do the healthcare professionals give anything before and now after your study in doing any of these procedures?
So what Dr. Rivlin talked about, the cost of one versus like the current way of doing things with propofol and maybe an IV and a nurse, if you're going to be requiring that type of anesthetic, particularly in the emergency department, to reduce a fracture, we don't do that type of aggressive thing in the fracture clinic. If we need to do something that major, we would have to take them to the emergency department from the fracture clinic, and then we'd have to set up that whole thing. So when you're looking at this unmet need, you're looking at it for these sort of less intense procedures, which is just purely a subjective and quality of life or a quality measurement where you're providing a better patient experience, better pain relief, because it's just not done appropriately in these outpatient settings. And that's all that we're measuring in our control group. We're just showing that there's an unmet need. But if you are comparing it in terms of a cost, that's purely a cost of the drug versus the cost of someone taking their Percocet or their current medication. I think that the cost of one medication versus a Penthrox, I don't know what the difference is there. It would be in the dollars, maybe $10 or something. We're not talking about thousands of dollars when we're talking about needing to use an IV and staff and a medical bed. So one of them is purely the quality of life and the patient experience, where there will be a negligible change, a difference in costs, where there would be a much more greater type of need or intervention that would have a huge difference in cost, because you have to measure all these ancillary costs, not just the cost of the medication. So to answer the question, in the fracture clinic, we don't do all that, because if they need it, they go to the emergency department.
Yeah. All right. Okay. So any other questions? Yep. So the question is, do we use Penthrox at Sunnybrook? So Joe to answer first, and then followed by Leon. Ask in the Humber, what do you guys do?
So in our fracture clinic, no, we have not used it. We wanted to initially introduce it in a study protocol, and that was very difficult to do. But it's now FDA or HPB approved, so we can get it in the hospital. We actually can use it. It's just a matter of patient preference now, or doctor preference if they want to use it. But we don't use it now. Whether it's used in the cancer clinic for bone marrow biopsies or other things, I don't know. I think it may or may not be. But I know it's used in urology for cystoscopy. They are using it.
Leon, what do you guys do at Humber?
Yeah, so at Humber, we use it in the emergency department. I think that's a good question. We use it in the emergency department. We also use it, and my understanding is we use it in our cancer center in oncology, right? And then we're looking to, at least the urology department and the obs-gyne service is looking to start using it as well. Yeah.
So many years ago, when I was doing the palliative of the bone mass, I actually saw a lot of the patients when they had to put into the simulation bed. It was so painful. So we had to drug them with morphine dilaudid. Takes an hour to settle, come in, and then we bring the patient back. And then afterwards, it lasted for 6 hours. So they went back to the floor very drowsy. So at that time, I was trying to use the sublingual fentanyl. So I was thinking of potentially this Penthrox can be of use when patients with bone metastasis, when they have to come on to the simulation. Now I'm going to ask Muna. Muna actually is our family doctor in the breast survivorship clinic and also doing the gynae clinic. So she can share the experience when patients doing the endometrial biopsy. I want to say, okay, when I was introduced this a few years ago, nobody cared doing the procedure. doing the painful simulation, patients, you guys just have to suck up the pain. And even in the orthopedic clinic, fracture clinic, they emerge, you just have to suffer, okay, and wait for like an appropriate long-term medication. But since then, things have changed. People are using the in the cystoscopy unit. Mona is going to tell you the gynae at the Princess Margaret Hospital, the bone marrow biopsy, they are doing the Penfrox. And in the women's, I just heard this morning, at the women's hospital at the Mount Sinai Hospital, they're actually doing a randomized studies of using the Penfrox when patients go for the IUD, removal or insertion, and the endometrial biopsy. So Mona will be able to tell us more about this.
Hi, everyone. I'm Mona. I'm a GP oncologist, and I run the survivorship program here at Sunnybrook. But I also have a women's health clinic in the community, which is close to Women's College Hospital. And I've started using Panthrox in my patients, especially like during procedures, including endometrial biopsies as well IUD insertion. And I saw really good results for my patients because otherwise we just give them Tylenol or Advil, which is not enough to reduce their pain. So now I've been using Panthrox. I have very good results from patients, better satisfaction, reduced pain. And as you know, most of these procedures, especially like IUD insertion, we use it's mainly for like younger population. So Panthrox also helped them to reduce their anxiety, and that will also increase the uptake of like using IUD as a contraception. And we know now there's also more interest in considering like Panthrox as a pain medication for IUD even in hospitals. There's a research that is coming up at Women's College Hospital where they're going to use Panthrox as a pain medication for IUD insertion. There's also at Mount Sinai Hospital. So we hope that also Panthrox can be introduced here at Sunnybrook. Based on my experience, I think it's very effective, fast onset, good patient satisfactions, reduced pain, as well as anxiety for patients, especially women. I think we need to do more to reduce their pain, especially going through these painful procedures.
Okay, so Joe is going to add, and I'll ask Leon to prepare because we know that in Australia, in BC, the paramedic, the pre-hospital, they use a lot. So after Joe's comment, I want Leon to come to share the experience that people use elsewhere. We, Canada, are developed country, but in terms of this, we're actually quite back behind.
I would agree with that because we talk about patient-centered care and patient perspective, and the cost is one thing depending on the situation, but the patient-centered care is another thing. And like I said, I think that we've proven that there's an unmet need, and this can potentially fill that gap. But I just want to comment on the anxiety component. I think that is a major thing. It does provide a good anti-anxiolytic type of help, and helps with patient comfort at the time. And I can speak from personal experience because I actually did use it. So it hasn't been used as a patient. Yes, I use it as a patient, and it was extremely helpful. And you can imagine a doctor having to have a procedure. It was an injection for a cervical nerve root. I was very anxious, and I can tell you this made a big difference. It was help with pain and with anxiety. So yes, anxiety and analgesia.
There can never be a better case when compared with the doctor himself is a patient, right? That speaks the most. And I just want to give a little bit of the advertisement. Okay, we probably are going to have a dinner talk on February the 19th at a very nice restaurant with the people from the Princess Margaret Hospital to come as a speaker. And unfortunately, that place only allowed 20 people. So once it's confirmed, I'm going to send out. I hope that our nurses and the radiation therapists will come to attend, because I think that potentially on the radiation therapy side, I think that there is potential utility in relieving the suffering when the patients go for the simulation. Okay, Leon, talking about the Australia and BC.
So the use of Penthrox in a pre-hospital setting is really what we're looking at in the outback, effectively in BC, the outback in BC, the outback in Australia, and of course the wilderness areas in BC where you really don't have access to healthcare other than paramedics who have to then transport you there. And we actually talked a little bit about this when I presented at the Trauma Association of Canada conference back in May, and we had a whole host of individuals who weren't they were in a pre-hospital setting. They weren't in the outback, but they were in a pre-hospital setting, similar issue where what do you do in a helicopter? How do you administer the drug when you're trying to get these injured soldiers back to local hospitals? So it's a similar sort of a story in all of these situations where you have somebody who's down, who's injured, who usually has an orthopedic injury, or I guess in the trauma setting with the soldiers, it's unfortunately a penetrating injury with bullets or shrapnel. And in those cases, we administer the Penthrox. The paramedics for the Canadian Army use it a little bit off-label, and they will use more of it but then the reasoning is it's also given to young, healthy individuals as opposed to people who have other comorbidities. But at any rate, it's being used extensively, and it's just been very slow to pick up here in Ontario for a multitude of reasons. But I think one of them is also because we're only starting to use other medications in a pre-hospital setting as well. Like, for example, the use of hydromorphone in a pre-hospital setting is only coming around now, or injectable NSAIDs is only starting now. So we really are behind the ball. But our peers, our peer countries are using it extensively.
Well, I think our increase in use might be coming from Donald Trump, that they would ask us to use this Penthrox instead of the fentanyl. Anyway, let me just see whether there is, my God, what a joke that I have. Okay, so I don't see any questions here right now, but I think what we do is we are now trying to introduce this concept to Sunnybrook, and hopefully 5 years from now, the company and together with the healthcare professional, we will be able to get this under the medication-free supply from the Cancer Care Ontario or from the Health Canada. So I think that hopefully 5 years from now, everybody will have this available. So with that, I want to thank the two speakers and the sponsor, Paladin, and thank you very much. And when we send out the notification about this dinner talk, register as soon as possible, okay? We guarantee it's a good talk and also a good food. Thank you very much again. Take care.